Okay, so let's get started, boys and girls. Yes, so I'm your physiology faculty, Dr. Reena, and I'll be taking your FMG on the app. My हाँ बोल हेलो क्या बोल रहा है वो लाइव है Okay, so now I'm your physiology faculty, Dr. Reena, and I'll be taking your physiology in the month of September. Right? It is scheduled in the end of September, and I hope we have a very good session where we'll be having live online classes, and we'll be trying to deal physiology in a very conceptual and a comprehensive manner. So for now, let us just have a review on the live questions on the questions which we had this time in our NEET PG. Now remember that many of the all these questions are the sources which I got, but if you think that there could be questions with some other options, so you can tell me ki no ma'am, this was not the correct option, or if you think that the question was something else or there was any another question, then also you can report me. Okay, so this is the first question which I got. Identify the graph. I could not get the options. If you have, you can let me know so that I can add up on and do the final, correction from my side. So this was the graph which was shown, and this graph is basically a graph of a capnograph. So I don't know what was exactly asked to you, but usually जो इसमें question पूछते हैं वो यहाँ पूछते हैं this, that where is the maximum carbon dioxide level. Okay, where is the maximum carbon dioxide level? So you see that this is actually basically the graph of the capnograph or the capnography, where this point, okay, this point which is measured as the maximum end expiratory CO2. So this is the end tidal carbon dioxide, which is the level of carbon dioxide that is released at the end of an exhaled breath. This is very important because it reflects the adequacy with which the carbon dioxide is carried in the blood back to the lungs and exhaled. And one of the very important procedures also applied when the patient is on anesthesia. Very important to monitor the cardiopulmonary resuscitation in patients with cardiac arrest. Right? So you can see that this is the baseline. This stroke is the downstroke, is the inspiratory stroke, where the person is inspiring and giving out with full expiration. So when you attain the plateau, that is the stage where maximum carbon dioxide has been expired out. So this procedure is similar to the procedure which we bring about for the calculation of the anatomical dead space. Okay, we do the anatomical dead space, and it is called as the Fowler's method, which is the single breath nitrogen technique. So आपको याद होगा, what do we do in this? We ask the person to breathe 100% pure oxygen, and we are going to collect expired sample where we are going to measure nitrogen, where we are more importantly considering to find out the anatomical dead space. So many of the times I've taken this in my lecture also, and I tell you that this question is very simple. When you inspire a known volume of air, like in this case it was 100% of oxygen, you know that the first part of the inspired air is going to be here, right? The first part of the inspired air is going to go towards the end of the alveoli, एकदम अंदर. ठीक है, और ये वाला जो पोर्शन रहेगा, this will be the last part of the inspired air. This is going to be the last part of the inspired air. But when you are expiring it out, ठीक है, जब आप बाहर हवा निकाल रहे हो, when you are expiring out, this last part of the inspired air will actually become the first part of expired air. And we know that this is anatomical dead space. This is the portion where only oxygen will be present, because remember, we are not giving air, which is a mixture of oxygen and nitrogen, but we are only giving pure oxygen. So at this level of anatomical dead space, which is the phase 1, there is no nitrogen, no nitrogen. This space where there is no nitrogen, tells us that this is purely anatomical dead space which does not take place in any gas exchange. It is just the conducting zone. Now gradually what happens is that this air, okay, is going to get mixed with the alveolar air, because the alveolar air will come and travel now because it has to be expired. So in the second part you will see that the nitrogen concentration rises. Okay, the nitrogen concentration rises, which means now it is a mixture of two parts, that is the dead space air and the alveolar air. The dead space air and the alveolar air. When you achieve the plateau, that is the time of this plateau where maximum nitrogen has been expired, because that is the part which is coming from the alveoli, and this plateau, that is the phase 3, is the last part of expired air. It is the last part of expired air. So when you attain the plateau, that means maximum nitrogen has been expired out. And the last part of the expired air is also a very, very important question, because this is the air which is taken for alveolar sampling. Okay, this is the air which is taken for alveolar sampling. So if you have to take an alveolar sample, the last part of the expired air would be most beneficial. Now, after completing this manual, you ask the person to take a forceful expiration. That forceful expiration will give you closing volume, and this fourth phase up to the residual volume, that is the part of the air which is coming from the apical alveoli. You know that the apical alveoli, they are already inflated, they are already large, they have got low compliance because they are already filled with air, as the lungs are subjected to more negative intrapleural pressure towards the apical area. So that part of the alveoli will empty out with forced expiration. So this maneuver is with extra forced expiration, right? So if this question was there, remember this question is related to capnography, which is measuring the end tidal carbon dioxide, and this is the point where there is maximum end tidal carbon dioxide. Moving on, next was the question related to special senses, that is the sour taste is mediated by which receptor? The options were the transient receptor channels TRPP3, metabolic, GPRC, that is the G protein coupled receptor R1 and R3. I don't know whether the option was TRPP3 or whether it was INI-CET channel, but I have taken both of them. So if there's something wrong, you can let me know ki no ma'am, that was the correct option. Now, if you consider your taste, there are 4 primary tastes, but now we even say that umami is also coming into the primary taste sensation. So you have got sour, salt, bitter, sweet, and umami. Those channels, those substances which open directly the ion channels, ठीक है, जो directly ion channels को open करते हैं, and therefore they are very fast, are called as ionotropic receptors. Ionotropic, which is your salt and sour. Those which are using G protein and then a second messenger, ठीक है, they take a bit more time. These are your metabotropic receptors. Metabotropic receptors. So as far as bitter is concerned, you know, it will always be the G protein, sweet also G protein. Umami has got its own specific M-glutamate R4 receptors. Salt and sour are by the ENaC receptors. So as per this question, the correct answer would be this, that is TRP, trans receptor potential channels. Remember, this transient receptor potential channels are also important in pain physiology, where they are V, that is valaloid, A, that is anchorin, menthol. So this is the recent part where I've seen that the receptors are very, very important. So let it be the receptors not only of your special senses, but as far as the receptors are concerned, even endocrines. If you go through the NEET PG questions of your couple of years later, you will find earlier you will find that receptor ka question is always there. So jahan pe bhi receptors hai, where are the receptors, how do they act, is coming, right? If you remember the last NEET PG question, there also there were pictorial questions where the question was related to tyrosine kinase, and then the sequence was also asked. So receptor wala portion jo hai general physiology ka, that should be very, very thorough to you. So finally, sour taste is by the ENaC, which is the transient receptor potential P3. The next question was related to cerebellum. Alcoholic gait, nystagmus after a roadside accident. Which lobe of the cerebellum is affected? Flocculonodular, dentate, anterior or vermis? Now, when you are studying cerebellum in physiology, always open your anatomy and you will see that you can bring about an anatomical division of the cerebellum. You've got anterior lobe, posterior lobe, you've got the flocculonodular lobe, lingula, and all that structures. Then you give a functional classification depending upon their function and depending upon their development, right? Depending upon their development. So you see that the area which is the cerebrocerebellum, we also called as the neocerebellum, which is phylogenetically the newest part of the cerebellum, has got reciprocal connections with the motor and the premotor cortex, and this is associated with the planning and programming of movements. So planning and programming of movements are the functions of the neocerebellum, the portions of basal ganglia and premotor area. Okay. This spinocerebellum, also called as the paleocerebellum, is the area that is associated with the smoothing and coordination of movements. Smoothing and coordination of movements. It is also called as the comparator servo feedback mechanism. Comparator servo feedback mechanism. What do you mean by this comparator servo feedback mechanism? If you remember, the cortex is sending the corticospinal tract down to the alpha motor neurons to bring about the voluntary movements. One copy of that blueprint or one copy of that plan is also being given to your cerebellum. And various pathways, okay, they're coming from the periphery and giving information to the cerebellum. So the cerebellum, that is especially the spinocerebellum, can compare that whether the ongoing plan is absolutely the same which is performed. So whatever was planned has to be executed, and if both of them shows a mismatch, there is going to be a correction brought about by that. That correction is going to be brought about by the climbing fibers. The climbing fibers which can bring about the LTD, that is long-term depression of the parallel fibers towards the Purkinje cells. Right? So long-term depression can be brought about by the climbing fibers to the inputs which are coming to the Purkinje cells via the mossy fibers to bring about the correction of the ongoing movement. So this is the comparator servo, that is spinocerebellum. Whereas vestibulocerebellum, which is phylogenetically the oldest part of the cerebellum and also called as the archicerebellum, that includes the flocculonodular lobe. It is going to give its inputs to the vestibular nuclei, and therefore it is the flocculonodular lobe, option A, that is going to result in alcoholic gait and nystagmus because of its connection to the vestibular nuclei. It is also controlling the vestibulospinal tract, the vestibulo-ocular reflex. They are all regulated by the flocculonodular lobe, which is the part of the vestibulocerebellum of the cerebellum. Right? Cerebellum mainly, if you remove cerebellum or if there is a cerebellar lesion, there will be alpha rigidity. So if there is a cerebellar lesion, there will be alpha rigidity. So the flocculonodular lobe is associated with your balance equilibrium, and therefore that kind of symptoms will be there with the flocculonodular lobe. RMP is predominantly by which ion? Potassium, calcium, sodium or chloride. Just go through your NEET PG questions, and every time the question is there on general physiology, on action potential, every time. So this basic question is very, very important, and it is a very simple, straightforward, repeatedly asked and learned question. It is definitely potassium. The reason for this is potassium has got maximum leakiness. Maximum leakiness. See, there are leak channels. These leak channels, their permeability to potassium is even 100 times more than to sodium. So this is the most diffusible ion at rest. This is the most diffusible ion at rest. If you look into the molecular weight of sodium is more than potassium. So I just write down this: molecular weight of sodium is less than that of potassium, right? I repeat, the molecular weight of sodium is less than that of potassium. But if you look into the size of the hydrated ion, okay, if you look into the size of the hydrated ion of sodium, it is more than potassium. So these channels, they have got a selectivity filter over here, right? They have got a selective filter over here. So even if the ion will come inside, it is not going to cross that selective barrier. It will not be able to cross that selective barrier. Because it has to cross through that barrier, it will lose its water molecules and it can easily pass through. But ऐसा नहीं होता है. This is not taking place in the case of sodium, because as I told you कि sodium का जो ये है, okay, the hydrated ion of sodium is more as compared to that of potassium. So that selectivity barrier is not going to allow the sodium to pass through, and so you will see that the sodium is not allowed, and so the maximum leakiness is with potassium. So even when you calculate your Nernst potential, okay, Nernst potential for potassium is around -90 to -94 millivolt. So every ion, sodium, potassium and chloride, they want that their Nernst potential should be nearest to the resting membrane potential. Okay? Every ion is going to fight for that my Nernst potential should be closest to the Nernst potential. My Nernst potential or my equilibrium potential should be closest to the RMP. But the only ion that is going to win the race is potassium, because of the very, very important fact that potassium has got maximum leakiness, or it is the most diffusible ion at rest, and therefore its Nernst potential is closest to that of the resting membrane potential in majority of the ions, majority of the tissues. Remember, this is the ion which has got a maximum contribution to RMP. As far as sodium is concerned, it has got no role in RMP. Seems very, very strange. It is. It has no role in RMP. Don't consider the sodium potassium pump. No role in RMP. It has got a role in the depolarization phase. It has got role in the co-transports, in the counter transports. It is very, very important to maintain the osmolarity of the ECF, and therefore contributes to the ECF volume, right? Osmolarity and to the ECF volume. ठीक है? And depolarization में एक बात हम ध्यान रखते हैं, because ये आ भी चुका है कई बार, this question has come, that depolarization is because of the sodium ions in majority of the tissues. The exception which we need to remember, boys and girls, is that calcium is important for depolarization in the smooth muscles, right? And in your essay note. So this was also a repeated MCQ जो हमको ध्यान में रखना है. Next, a man having difficulty in sleep during night because he has got a habit of drinking coffee before bedtime, and what is the role of coffee in wakefulness? A very, very interesting question, very unique and a very interesting question related to sleep physiology. And you see, sleep and the EEG waves are very important or must known topics. ठीक है? So इसमें the answer is that it blocks the adenosine action. Adenosine is actually associated with sleep. This caffeine is a xanthine. We know that it binds to the adenosine receptors A1 and A2, kind of blocking of the adenosine receptors. And because it is blocking this adenosine receptors, you are becoming more alert or resulting in lack of sleep. So caffeine via your adenosine, and adenosine normally promotes sleep, ठीक है? But it is being blocked by caffeine, and therefore it makes you more alert. Remember this table, which is from Genong and almost every time being taught in the classes, where the role of the neurotransmitters has been given to you and must be studied. So we can see when there is increase in the histamine, decrease in the GABA, there is increased activation and waking. Whereas increase in GABA, decrease in histamine, NREM sleep, whereas REM sleep is contributed by your acetylcholine. Remember, one of the most important side effect of the antihistaminics is sedation, right? So the question can be put in this form also, antihistaminics and sedation. So you must know that what is the role of histamine in wake sleep cycle, right? So the suprachiasmatic nuclei of the hypothalamus, is the biological clock, or the circadian rhythm is maintained, and it is the preoptic area which is supposed to be the sleep center in the hypothalamus. So the question is, answer is A, that is blocks adenosine and causes wakefulness. Now, moving on next, which receptor helps in the improvement of insulin resistance in type 2 diabetes with regular exercise and physical activity? Options: GLUT 1, 2, 3, 4. One of the very favorite and repeatedly asked question and almost every time taught in the theory, never missed out. Out of these given, glutes, the only glute which depends upon insulin, or is also called as an insulin dependent glute, is GLUT 4. Okay, GLUT 4, which is insulin dependent, which is present in your adipose tissue and muscles, especially your skeletal muscles. Okay, so these are the areas, that is adipose tissue and muscles, where the GLUT 4 is present, and the entry of glucose via the GLUT 4 depends upon insulin. Okay, in liver also the insulin is needed. Okay, liver maybe the insulin is needed for glucose uptake. However, insulin does not increase the glucose uptake via glutes, but it increases the activity of the enzyme glucokinase. Because of the increased activity of the glucokinase, the intrahepatic level of glucose will fall and the glucose will be taken up. So liver, adipose tissue and muscles, these are the three sites in the body where glucose entry requires insulin. And adipose tissue and muscles mate is via the GLUT, but in the liver it is by the increase in the activity of glucokinase by your insulin. Apart from this, you must remember that in intestine and in your PCT of kidney, you have got SGLT 1 and 2. And yahan par there is no need of insulin for glucose transport. So this also gives you an idea that insulin, glucose reabsorption is both active and passive, because glutes will be passive, facilitated diffusion, and SGLT will be secondary coactive transport mechanism. Yeah, another question that was related to the taste sensation, which of the taste is absent in which of the taste bud? Options were filiform, foliate, fungiform or circumvallate. So the correct answer is filiform. See, these are the four basic papilla, that is your foliate, fungiform, filiform and circumvallate, out of which the filiform is not supposed to be associated with the taste bud function. As far as the taste map is concerned, okay, initially, there was a taste map which was given where the tip of the tongue had maximum receptors for sweet, back for bitter, anteriorly salt, and posteriorly it was sour. But see, this type of the taste mapping is not acceptable now. Every part of the tongue can perceive every taste, but you can assume that the threshold or the stimuli required would be less. But if you keep a crocin tablet even at the tip, or even if you keep sugar at the back, you will perceive the same taste. So this taste pathway is no longer acceptable, right? Or the taste mapping. Another thing, remember the ventral posteromedial nuclei in the thalamus is the relay center. So because you must know the specific nuclei in the thalamus. So that is ventral posteromedial nuclei of the thalamus. Yes. 50-year-old women with dyspnea, with chest pain. Which of the following proves that she has aortic stenosis? A good question rather. Increase in the myocardial oxygen consumption is seen with increase in the pressure work than volume. Aortic stenosis causes reduced pressure at aortic valve. Workload has nothing to do with myocardial oxygen consumption. Increase in the preload more than the afterload will cause increase in work probably. I hope all these questions were there. अगर कोई ऐसा question लगता है कि ये नहीं था, ये था, please add a comment. So I would also come to know. Now this is a basic question that is actually asked on the myocardial oxygen consumption. The myocardial oxygen consumption has got a linear correlation with heart rate. So if you increase the heart rate, the myocardial oxygen consumption is going to be increased. Now what is work? Work is equal to force into displacement, right? Force into displacement. The human heart is subjected to two important things. One is preload and the other is afterload. What is preload? It is nothing but your venous return or your end diastolic volume. You know that it should be within physiological limits as far as the Frank-Starling's law, right? As far as the Frank-Starling's law, it should be the within physiological limits. So what is the Frank-Starling's law? That within physiological limits, the force of contraction will increase if the initial length is increased. So the Frank-Starling's law is totally based upon your length tension relationship, that is based upon the active tension that will be developed with the maximum cross bridge activity. So if you increase the preload, then also the work done is going to increase and the oxygen consumption is going to increase. Okay? But if you increase the afterload, what is afterload? It is the resistance against which the heart has to pump the blood. Okay, the resistance against which the heart has to pump the blood. So हम लोग बोलते हैं ना कि semilunar valves will open when the left ventricular pressure will become more than that of the aorta and the right ventricular pressure will become more than that of the pulmonary artery. तो ये कौन से प्रेशर की बात हो रही है? ये प्रेशर है आपका डायस्टोलिक प्रेशर. Diastolic pressure. So just imagine if there is aortic stenosis or if there is systemic hypertension, what will happen? Now the left ventricle have to increase the pressure more than normal. So normally it is 120/80. They'll have to work more than that. 80 से भी ज़्यादा उनको काम करना पड़ेगा to open the valves. That means the afterload will increase, and the increase in the afterload will bring about much massive increase in the work done and more oxygen consumption. So the afterload to the heart is more dangerous than the preload. ठीक है? And इसमें अगर आप वो LV loop देखेंगे तो you will get a typical LV loop which is long and narrow. Long means the end diastolic afterload has increased because now they are not opening at pressures more than 80 but even at the pressures more than 80, much more than 80. So if you compare this to your normal AV loop, suppose this is the normal left ventricular loop, अगर आप इससे compare करेंगे तो आपको दिखेगा कि height बढ़ चुकी है but ये narrow हो गया है. Even the end diastolic volume is decreased. Right? So this question is a very conceptual question where you need to have an idea about the preload and afterload. Then what is preload? What is afterload? So remember that when it is aortic stenosis, and the best answer is that in myocardial oxygen consumption there's going to be increase, but ज़्यादा increase तब होता है myocardial consumption जब pressure work बढ़ेगा as compared to volume. Both will increase लेकिन pressure ज़्यादा बढ़ाएगा. ठीक है. और इसमें अगेन इमेज बेस्ड क्वेश्चन इज इंपॉर्टेंट विथ LV loop. Now, a patient had sunburn, okay, sunburn, and now takes a bath with 40 degrees and he feels pain. तो एक तो उसको sunburn हो गया, मतलब sunburn की वजह से भी pain था, और अब वो गर्म पानी से नहा रहा है, which is about 40. What is the pain caused by? Thermal receptor hyperalgesia, innoxious thermal receptor allodynia, thermal receptor allodynia, noxious thermal receptor hyperalgesia. So this is a feature where there is an innoxious thermal receptor and allodynia is also there. Remember that you have got free nerve endings. You have got free nerve endings which are responsible to transmit your pain and temperature. ठीक है? Now, when the temperature is more than 40 or it is more negative, it is very, very cold. Apart from the temperature, the pain receptors also get activated. So this sunburn and 40-degree bath is allodynia. And what is allodynia? It is the pain even to a non-painful receptor. It is a pain even to a non-painful stimuli because it gets activated because of the other receptors. So sunburn, and after sunburn, a bath with a hot water is going to exaggerate pain, right? Next, again a question on receptors with the correct matching. So receptors, whether it is endocrine, whether it is special senses, whether it is cutaneous, are one of the high yield areas. Mechanical receptors and their function, and choose the correct option. Pacinian corpuscles, fast vibration. Ruffney's, sustained pressure. Meissner's, stretch, or Merkel's, slow vibration. A very simple and a very repeatedly asked question. Definitely it is Pacinians with fast vibration. So, if you look into your cutaneous receptors, you can classify these cutaneous receptors as superficial and deep, and you can classify them as rapidly adapting and slowly adapting. ठीक है? So, rapidly adapting are Pacinian and Meissner's. Slowly adapting are Merkel's and Ruffney's. Out of which superficial ones. Which are the superficial ones? Meissner's is superficial, Merkel's is also superficial, but Pacinian is deep and Ruffney is also deep. Best option among the four given is Pacinian with fast vibration. Meissner's is a rapidly adapting superficial touch receptor. Merkel is also a touch receptor but slowly adapting. Ruffney, sustained pressure, yes, you can also say, but the best option among the other would be Pacinian with high frequency vibration. Ruffney is present around the joint capsule, most importantly stimulated with the stretch of the skin. Also important to identify the shape of the object when it is kept in the palm. Again, this can also come as an image-based question and very, very high yielding area and repeatedly asked question and always taken in the class. Yes. Now, after a right limb amputation, the patient is experiencing severe pain, phantom limb. What is the mechanism behind? Now we know that when it is a phantom limb, there is law of projection. There is law of projection, which is based on the concept of cortical plasticity. Okay, based on the concept of cortical plasticity. ठीक है? And what is cortical plasticity? That when a particular limb, when a particular organ of the body, or suppose the thumb is amputated, that area will have now extended connections. Okay, the remaining part will have extended connections in the cortex. right? So that is what is cortical plasticity or the law of projection. So if it is a right limb amputation, obviously what happening will be the neighboring fibers of the somatosensory area extending into the right hand area. That means जो part ampute हो चुका है, उस part का जो बचा हुआ area है, whatever area is there, that will now have extended connections with the cortex. Okay, it will have extended connections with the cortex. That is called as cortical plasticity and comes under the law of projection. So one of the important sensory laws. Next, very simple question. Gastrectomy needs supplement of vitamin C, D, B12 or A. So what is it? Very simple. You know that vitamin B12 is going to be absorbed in the ileum, but it requires intrinsic factor that is coming from the stomach. So therefore, because of the deficiency of the intrinsic factor, there is failure of absorption of vitamin B12, and therefore the vitamin B12 supplementation has to be given with gastrectomy. So, absorption of vitamin B12, calcium and iron must be studied. Calcium, iron and vitamin B12, they are important demanding areas for question. Gastrectomy decreases which hormone? Remember, it is going to decrease ghrelin, because ghrelin is one of the most important hormone that is coming from the stomach in the fasting condition, and it is known to increase appetite. Okay, so this is how you will be increasing your 360-degree rotation of what topics can be considered if there is a particular MCQ. So you don't have to remain stick only on that gastrectomy and vitamin, but gastrectomy and which hormone being affected should also be known to you. So this is all, I think, from your mentor Dr. Reena, your physiology faculty at Medway. My best wishes is very important, and I always believe that discipline is something which can only bring about changes. Just try to be disciplined only 1 hour per day. Continue it for 1 week, for 1 month, and you will find massive changes in you. Whenever you are studying, stay away from your mobiles. Either switch it off or put off the data. When we have to sit in the exams, at least 2 to 3 hours concentration span is needed. And उसके लिए we have to make a practice from the time when we are studying. So जब आप पढ़ रहे हो, mobile data को off करेंगे so that there is no distraction. Even if there is distraction, keep your mindset very, very strong that no, I'm not going to waste my time. Time is precious, one of the most valuable thing which we cannot buy, right? So see you very, very soon on board with Medway online classes, end of September. Best wishes. Please point a note if you like the class. Let me know. Please share a comment if something more was needed or more questions were there. Thank you and have a nice day.